a big advocate of Medicare Advantage and think it's a very forward-thinking business model that is reflective of what we're now seeing in managed Medicaid, some commercial ACOs, and possibly even some echoes of what we're going to see with future Medicare ACOs. And so it's something that's near and dear to my heart. When my team asked me to do it, I did warn them that I'm always traveling, and I am traveling today. So Kelly is helping me out. I'm in kind of a rural part of the country, rural part of the South today. So she's helping me out with the slides and stuff here. Before we jump in, when we're talking about Medicare Advantage, we're really talking about it from a couple of different perspectives. We're talking about Medicare Advantage for Medicare Advantage plans. And so those are, groups that are actually Medicare insurers or dedicated Medicare Advantage providers. However, pretty much every provider out there, except for maybe PEDS and really OB focus groups, are going to have some mix of Medicare Advantage plans within their payer mix. And a lot of groups can't readily identify these, but they're going to be called plans like senior, gold, silver, things like that. No reflection back to the Affordable Care Act, gold and bronze and all that sort of stuff. But things like Geisinger Gold or HealthNet Senior Plus, things like that, are classic plans. And these Medicare Advantage plans present a unique opportunity to providers because you are actually incentivized to do additional types of coding that we'll talk about, as well as to do additional quality measures. If you've ever had a plan come in and ask if they can send someone on site to do a chart audit to go ahead and look for additional opportunities or additional quality measures, that's most likely a Medicare Advantage plan. In addition, if you get these weird random checks because of HCC coding, RAS or coding, HEDIS measures, 5-star, any of those words on it, a lot of clinics don't actually know what those checks are for, and those are your actual bonus checks for Medicare Advantage. So for the vast majority of Medicare Advantage payers, they do actually pay back to the physician a piece of what they receive in additional compensation for doing a good job from the government. And if they're not doing that, you definitely want to have that conversation with your plans and get them to go ahead and start giving you that money. Any provider that does a lot of chronic disease management, be it primary care or a specialist, is going to have significant opportunities in the Medicare Advantage spectrum. So jumping into our first slide here, just a little bit of history of Medicare and Medicare Advantage. So most of us are familiar with Part A and Part B. Part A is hospitals and community health centers. Part B is the classic professional fees that most providers are charging against. But there is also, since 1997, Medicare Advantage, which is Part C. And Medicare Advantage is a concept where instead of having your classic Medicare, a Medicare-eligible patient can go ahead and sign their benefits over to a commercial insurance plan, and that insurance plan can go ahead and provide the same benefits to the patients. And the reason why patients would want to do this is oftentimes the Medicare Advantage plan will either have no copay or a lower copay, and then be able to offer some additional benefits of things that aren't traditionally covered under Medicare. And so it can actually be a benefit to the patient to go ahead and sign things over. Now, a lot of these Medicare Advantage plans are managed care plans, meaning that instead of going anywhere you want, like you can under a traditional Part B arrangement, you are limited to being within a specific provider network, but it's for a lower cost and for additional services. And then Part D is what was signed by George Bush, the second George Bush, and is the pharmacy benefit plan. Most often you see Part C and Part D mixed together, but they are separate portions of Medicare. Jumping forward to the reimbursement model, I'm going to simplify this, but I just really want folks to understand where this all comes from, because understanding the basic foundation of how these Medicare Advantage plans make money and kind of keeping that in the back of your mind helps you understand how you can partner with these plans and increase their reimbursement, and as a result, increase your reimbursement as well. So the reimbursement model is each county has an index of how much a standard Medicare member is costing the government, and that's tweaked every single year. Every single Medicare Advantage plan has to go ahead and then submit what they call a bid to CMS by June of every year, and that bid includes what sort of benefits they're going to provide, as well as what they're going to actually charge the government. And so I'll go through an example here, but typically that's going to be below what the index is for that particular county. Starting in October, the plans can go ahead and start marketing the new benefit package for the following year, and then the plans go into effect on January 1st. That open enrollment period that we always hear about is that October timeframe, October through December, and that's when most plans are only able to go ahead and sign up new members. There's a couple of exceptions to that, the biggest ones being that dual eligible members that are Medicaid and Medicare, can sign up at any point, as well as anybody who is a 5-star plan, which is the highest level quality score, can actually sign up members at any point. And that's one of the big benefits of becoming a 5-star plan. Going on to the next slide, I actually have a really simplified example of how this works. So let's go ahead and talk about Miami-Dade County, where we do a lot of work. So the index rating for Miami-Dade County is approximately, this is a little low, but let's say it's $900. And let's say we're a Medicare Advantage plan, and we want to go ahead and submit our bid in June for $500. What Medicare is going to go ahead and do then is split the remaining amount, and we're going to go ahead and take part of that remaining amount, and it's actually going to be an amount that we can use for additional medical services. So these are things that are typically not covered under traditional Medicare benefits. So these $200 in this case, we have to go ahead and use for medical benefits. We can't use it for profit. We can't use it for overhead. It has to go directly into patient services. But this is one of the ways that these Medicare Advantage plans can be very competitive. In addition, the star rating, which I'll break down a little bit more on a subsequent slide, can give us a bonus as well. So let's say that adds in another $1. And then in addition, there's the risk factor, which comes from the diagnosis codes that are put in for a member. And so Medicare actually increases the amount of reimbursement for each diagnosis that's considered a, it's an HCC code is what they're called. So each diagnosis that Medicare has said is going to increase the cost of treating this patient receives an additional reimbursement. And so because of that, you can see we started off with a $500 bid, and we can quickly end up with $1,600 being reimbursed. So this is something that's highly lucrative for the Medicare Advantage plans, and then presents an opportunity for the providers to go ahead and tap in and receive some of that additional reimbursement. Going on to the next slide here, HCCs. So on the previous slide when I was talking about how Medicare actually rewards providers, or compensates providers is a better way to say it, for more complex patients, that's through what are called HCC codes. So each HCC code has a risk adjustment factor associated with it. And that risk adjustment factor says that based on this diagnosis, we're going to go ahead and give you an additional compensation for treating that member. The HCCs are submitted through what's called a RAPS file, and that's done directly by the health plan. So the typical workflow is you as a provider are going to be creating your standard CMS 1500 forms or HCBAs and sending them into the Medicare Advantage plan. They're going to go ahead and process those claims and either give you your capitation or reimbursement back. They're, however, going to save up those claims and actually submit them to a RAPS file off to Medicare, and that's how Medicare becomes aware of what conditions this member has. And anything that's categorized as having a higher reimbursement, a higher risk adjustment factor, the Medicare is actually going to go ahead and pay more money to the Medicare Advantage plan. And so this is one area where technology, we're going to talk specifically about NextGen in this presentation. Typically we stay vendor agnostic, but NextGen has done a very, very good job of actually incorporating a lot of this into their workflow. A couple of the other EHRs have If this is something that you're interested in and you're on NextGen, we'll dive into this in a little bit more detail. If you're on another EHR, feel free to reach out to us after the call, and we can let you know whether or not your EHR has this capability in it or not. Going on to the next slide, for HCC code management and recertification, NextGen has built into it an integrated diagnosis search. And so this is one of the big features that's most important, is being able to flag for your physicians at point of care what items require risk adjustment, which items are eligible for risk adjustment, and making sure that the physician goes ahead and recertifies those codes each year. The recertification process is really pretty straightforward. All that means is that you need to go ahead and document that code in a face-to-face encounter and put a status assessment and plan on each of those codes that you're documenting, and then submit that off to the health plan on a claim form, and they'll go ahead and include it in their RAP submission, and then you should get the bonus back from the plan for documenting that. Moving on to the 5-star rating, which is the quality rating system for Medicare Advantage plans. This is something that is highly, highly competitive, and it changes every single year, meaning that there's new criteria for Medicare Advantage plans within the star rating program. And then the programs are weighted against themselves, so you actually have to show improvement from one year over the other, and also weighted against each other. So becoming a 5-star plan is really quite a challenge, and off the top of my head, I believe there's 11 5-star plans for this current year across the entire country, so there's not very many of them at all. The 5-star rating system is becoming incredibly important when it comes to these plans' ability to survive and thrive. If you have successive years of having a low quality score rating, a Medicare Advantage plan with a continued low quality score rating can actually get dropped by Medicare, and they can no longer be eligible for submitting a bid and becoming a Medicare Advantage plan. We're starting to see some really interesting things from a contracting perspective on this. We're starting to see that plans are taking providers that have better quality scores and actually putting them higher in the search results when you go to their website and do an eligible provider search. We're also seeing it greatly impact contract negotiations with Medicare Advantage plans. So an example that I'll talk about without naming any names is a group in California where they were negotiating a contract with the Medicare Advantage plan, and they were asking for more money than the Medicare Advantage plan was willing to pay. So the contract negotiations fell off. The star ratings for that year came out, and the plan got 2.5 stars, which is really not very good at all. Really shows a need for some significant improvement. The plan knew that this provider group had a 4-star rating by themselves. If you just looked at their providers, and sure enough, they came right back to the table, and suddenly that amount that seemed too expensive before was just right, so that way they could go ahead and get their star rating up. So we are starting to see contracting based on who has good star ratings, which providers are following the quality measures, and which providers are not following the quality measures, and that's impacting contracting pretty significantly. CMS does go ahead and list on their website for each plan what the star rating is for that plan, so it's right there in the face of Medicare members as they're signing up or looking for Medicare Advantage plans. And again, only 5-star plans can market and accept new members all year round. So while the more stars you get, you actually get a bonus back from Medicare. Once you get to 5-star and being able to market and sign members up all year round, that really is, it's almost impossible to put a price on that because of the competitive advantage it gives you. Within the 5-star system, there's a couple of different components. The first is HEDIS, and HEDIS is very similar to what we're used to for PQRS, or the Meaningful Use Clinical Quality Measures. There's actually quite a bit of overlap between those different programs, and it's actually tracking different initiatives, and different care guidelines about how the patients are being treated. So a good example is whether or not the patient's LDL is controlled. So HEDIS is just a standard set of measures that you need to track and keep an eye on as a Medicare Advantage provider. Going on to the next slide, there's a couple of other monitoring systems as well, and these are actually quite interesting. There's the CAHPS and the Health Outcomes Survey. So these are two surveys that are actually sent to members, and the CAHPS survey has, and the Health Outcomes Survey asks a whole bunch of questions from the member's perspective about whether or not their care is improving, what sort of quality they're getting from the Medicare Advantage provider. And they're both pretty long questionnaires. You wouldn't think a lot of these get filled out, but, you know, being Medicare age patients, they seem to have the time to go ahead and fill out a survey that you or I might throw in the trash. So there is usually a high rate of return on these surveys. And these are things that are very, very much from the patient's point of view. A lot of these Medicare Advantage plans focus on really trying to keep strong patient loyalty and much closer communication with the patient than you typically would see in just a commercial health plan. You know, you take a standard commercial health plan, they're not going to be reaching out throughout the year because there's no survey that comes at the end of the year that's going to impact their reimbursement and quality score rating. Medicare Advantage, the exact opposite is true. They want you to know that, the plan wants you to know that they care about you as a member, so that way when the survey comes out, it's going to be much more favorable. One thing that's really important to be aware of is the survey occur in the spring time frame, and the Health Outcomes Surveys actually includes 2 questions now, and I'm paraphrasing, but the 2 questions to be very much aware of is, did technology impact the quality of your visit, and did the physician have everything that they needed to know about you during your visit? And the reason those are important is if you're implementing a new EHR system, upgrading an EHR system, doing anything having to do with technology or a physician's competency with their EHRs, don't do it during the survey period, because if the patient goes in for a visit and all of a sudden the physician's distracted because they have a new version of a system right in front of them, it's going to show up negatively on that survey. So it's just a good thing to avoid. And then moving on to the next slide here is medication. So the other major component of the 5-star is medication management. And this is actually a triple weighted measure, meaning that it holds 3 times the weight of a lot of the other measures that we've talked about. Medicare is very big on a couple of different components here, the biggest being high-risk medications. So there's this thing called the Beers List, and the Beers List is a list of all high-risk medications for senior patients. And each year, Medicare goes ahead and selects a different set of medications that they're going to go ahead and label as high-risk medications that they don't want Medicare patients on. And this includes a whole list of medications, but a good example is sleep aids, so things like Lunesta, Ambien, things like that. They don't want Medicare patients to be on those types of medications, because if a patient needs to get up and use the restroom in the middle of the night, let's say, and they're on one of these medications, oftentimes it makes the patient dizzy, and then they could fall and hurt themselves. So Medicare will actually very negatively impact your 5-star rating if you're prescribing these medications for patients. What's nice is, for the most part, Medicare Advantage plans have taken these medications and made them off formulary, so it's difficult for physicians to even prescribe them, patients even to receive the medications. If they haven't made them off formulary, then you do want to go ahead and be conscious of what this medication, this list of high-risk medications are, and go ahead and get the patient on an alternative medication. And your EHR can help you do that. The next page here is meaningful use. I'm going to touch on this very briefly, but one point of confusion is that Medicare Advantage patients actually don't count towards meaningful use when you're calculating your reimbursement that's needed to go ahead and get your meaningful use incentive. So meaningful use requires that you go ahead and have, that you receive no more than 75% of your Medicare Part B billings back as a reimbursement. And that's only Medicare Part B. That doesn't include Medicare Advantage, which again is Medicare Part C. And so that throws some groups off. Some groups don't even see enough Medicare Part B because they are Medicare Advantage specific organizations, And so there is a special Medicare Advantage meaningful use program out there. There's very specific criteria that you have to fall under. For example, 80% of members belonging to a single plan. However, if this is something that you do fall under, you do have the ability to go ahead and receive meaningful use, even though you're not billing against Part B. If you fall into this category, contact us offline and we'll be more than happy to help you. We've collected several $1 million for different Medicare Advantage organizations and meaningful use reimbursements over the past couple of years. It just is a very different process than what you're used to under your Part B benefits. So going on to the next slide here, there are a couple different provider models that are out there. What we do see is that, and it's just a fact, that staff models tend to have higher risk scores and higher 5-star ratings than IPA models. The reason for that is it's much easier in a very structured staff environment to go ahead and actively encourage, even demand that physicians go ahead and become active in the coding and 5-star process versus in an IPA environment. Of course, it's much more difficult to demand that type of response. We find that with all of the other initiatives out there, especially right now with what's going on with PQRS, meaningful use, the sequestration, et cetera, Medicare Advantage doesn't rise to the top of a priority list for an IPA doctor, and so a lot of times it just gets ignored. However, this is, again, one of the ways that you can significantly impact the revenue to your organization, especially in this time of downward trend in physician reimbursement. So going on to a case study on Medicare Advantage, we work really closely with Leon Medical Centers in Miami-Dade County down in Florida. And I'm just using them as an example. We do quite a bit of other Medicare Advantage work, but this is a great group to talk about. So they brought us an ultimatum a couple of years ago. They needed to go ahead and get everybody live on an EHR, and they needed to do that in 6 months. They had $1 million on the table that they were willing to invest in this, and that included actually redoing some of the centers to make it so that it was possible for the EHR to be put into the workflow, because some of the centers needed to be updated to support an EHR workflow. And they went ahead and gave us this ultimatum that we had 6 months to go ahead and pull it off, or they would end up pulling out the EHR system and starting over again. So what we did on this next slide here with the turnaround is we reshaped the organization by focusing on priorities in addition to just implementing the EHR. So we actually went through and presented opportunities for keeping and recertifying HCCs throughout the implementation process. So we presented these to the physicians at the point of care as care opportunities to be documented. And we not only did that on a physician level, but we actually did that on an organization level. So as we were implementing the system, we made sure that we weren't doing anything that was going to negatively impact the HCC score. In addition, we started using a dual process of using the EHR to track quality measures, and at the same time continuing to use a paper process to track quality measures and reporting those off of each other to make sure that we actually were capturing everything that was occurring in the paper world as sort of a safety net to ensure that we weren't negatively impacting the 5-star rating. And then we put in tools both at the physician level at point of care and at the organization level, again, to actually track utilization management for things like medications. By doing this, if we switch to the next slide here, you're actually able to take the first 2 months and upgrade the system, and then in the following 4 months, we brought 100 providers, and there's 7 different locations live on the EHR system. And we did this with a Go Live scorecard that I just mentioned previously, where we were keeping track of the HCC score, the 5-star rating, and the impact utilization, and trying to keep those under control at the same time that we were implementing. So if we go to the next slide, the results were pretty amazing. Just in that 6-month period with that $1 million investment, first of all, we were able to qualify for meaningful use. So that right there paid for the investment. We were able to get $2 million that very first year in meaningful use monies back. And subsequently, Leon has been able to qualify each year for meaningful use monies. We were actually able to do a 0.2 increase adjustment in the organization's overall risk adjustment factor. So not only were they able to stay stable, which was the goal during the implementation, but they were actually able to go up and by using technology in their risk adjustment factor. So they're actually able to make more money. If you calculate out what a 0.2 increase is against those numbers that I showed you earlier, you'll see that that quickly adds up to several seven-figure amounts. And then finally, they were actually able to get a 5-star rating from CMS that same year as well. So they had been at 4.5 stars and kind of stuck there for several years. And through the use of the EHR, they were actually able to get to a 5-star rating. So I want to jump in a little bit to talking specifically about Medicare Advantage and NextGen. And again, we never really talk about any specific EHRs during our insights calls, but what NextGen has out of the box, what we've been able to add to it has really brought a lot of additional functionality and capabilities to managing your Medicare Advantage population. And again, this is something that's available to Medicare Advantage plans, Medicare Advantage specific providers, or providers that just happen to see a couple of Medicare Advantage members mixed in, and is very applicable to all of them. So built into NextGen out of the box is some new features that are included in the 8.3 version of their system. The first is that there is a code check for HCC members, and so NextGen automatically figures out if a patient is going to be eligible for risk adjustment, and if so, automatically flags that patient and lets the physician know that there's HCC codes in play. The next little bit talks about how you go ahead and configure that in the application, and these slides will be made available to you so you can go ahead and follow that. But you can actually go ahead and click on that, and it brings up the care opportunities and the recertification needs for that patient once they're flagged as being a risk adjustment eligible patient. This is what the screen out of the box actually looks like. So you'll see at the top here, we've got a list of different different diagnoses. You'll see in this example, every single one of them has a Y in the left-hand corner, which means that there's an HCC that's associated with each one of those diagnoses. You'll also see that there's a star next to some of them, and that means that it hasn't been addressed in the past year, which means that it needs to be recertified during this visit or could fall off of that RAP submission, which means we qualified, in this case, the second code, the 112.4 had been certified previously, but has not been certified in the past year and could actually fall off, meaning we did all the hard work, we identified that the patient had this condition, and we're just not documenting it on a follow-up face-to-face encounter, and so we're no longer going to get credit for it. If we move over to the right-hand side, it goes ahead and shows the date last address, which is what's causing that flag with the little star on the left-hand side, the date first added, whether or not it's resolved, and then it actually goes through and says the HCC class and the HCC score, so this is the weighting, that risk adjustment factor that I was talking about, and the RX HCC class and the RX HCC score. I haven't spoken about RX HCCs at all during this call, but that's what actually impacts the reimbursement for the Part D side of things. So the HCCs are for the Part C part, and the RX HCCs are for the Part D part. And then the way that this template works is you go ahead and select the diagnosis, you go ahead and put a status, and the impression comments is where you go ahead and put your assessment details, and then you can go ahead and build a plan for that diagnosis. As soon as you do that, it drops into the bottom grid there and lets you know that you've certified that condition. It goes over the practice management system, gets filled out, and voila, we've recertified that condition. Switching to the next slide here, since Medicare Advantage is one of the most lucrative business lines out there in this current healthcare climate, we've spent a lot of time teaming up with NextGen to actually build these templates out further. So everything that I've talked about so far, you get with NextGen out of the box. We've actually gone ahead and put some additional functionality into NextGen to further enhance what is available to physicians. And this is something that's free for anybody that does use the NextGen system. It's something that you can get from us. We don't charge for it, and it's something that's actually getting rolled into a subsequent version of the NextGen product. In the meantime, though, we go ahead and provide it for you. So this says future state. We've actually just completed the beta process. So this slide is now about the current state of the HCC template. So we actually added quite a bit of additional functionality here. So the concept of trying to find out everything that's going on with these senior patients, some of which are very, very sick and are seeing several providers in the community, can be quite complex, especially because the patients aren't the best historians by themselves. And so we follow a couple of very specific concepts with these HCCs. We're trying to identify any possible opportunity out there where a patient has had an interaction with a provider or has come from another plan, or a series of events, let's say insulin being prescribed for the patient but them not being marked as diabetic is a classic example, has caused our logic to go ahead and say that there is an opportunity here to document an HCC. And so we actually pull the information from a whole lot of different areas. The first is when we do suspecting. So suspecting is a business rules engine that's built in to these NextGen templates, and it actually goes out there and it mines the patient's chart, and it has a whole bunch of business rules that say, okay, is the patient on a certain medication but yet does not have a certain diagnosis? And then it goes even one step further and says, okay, now that we've documented this patient as being diabetic, have they been referred off to an ophthalmologist, and should we be looking for some sort of ophthalmology condition that would actually be an additional HCC that would increase the score further? And so those are presented to the physician at point of care to go ahead and review and then make a determination. The second is conditions reported by Medicare. So Medicare actually sends the payers, the Medicare Advantage provider, or the Medicare Advantage plans, a list of all of the HCCs that they know about for that patient. And they do that monthly in something called the monthly operative report. The Medicare Advantage plans sometimes push those down to the providers, sometimes don't. If you ask for it, they are typically more than happy to give it to you because they want you to do everything you can to try to help them recertify these HCCs. And so we actually pull in that monthly operative report, and we present these as conditions that were reported by Medicare that aren't in the patient's chart. Now, these could be conditions that came over from another plan. These could be conditions that were submitted that came from a different provider. And these are presented at the HCC level, meaning that there isn't a specific ICD-9 associated with them. There's a one-to-many ratio of HCCs to ICD-9. And so these can't actually be documented as is because it's at the HCC level and we need to get down to the specific ICD-9. But what they're very helpful for is pulling the patient aside during the exam and saying, hey, you didn't let me know that you had been seen for, I'll use a crummy example, hypertension. So, you know, were you seen for that previously? And that can start a discussion with a patient who isn't the best historian and might lead the physician to identifying other conditions that they weren't aware of for that patient. The next thing that we have is outside conditions. So we also have the ability to pull in a claims file from the payer. And this claims file would include every single diagnosis that the payer receives, be it from another ancillary provider or be it from a hospital visit. And this is incredibly helpful because oftentimes patients go to see a specialist or they're hospitalized and they're diagnosed with an HCC, but they never get, that information never gets documented back in the primary care physician's chart. And so when it comes time to recertify that condition in subsequent years, there's no one to do it. The PCP doesn't even know about it. And so this presents those care opportunities to the physician at point of care so they can go ahead and document them as well. The way that this works is you have the ability to select from any of these areas, and then you can accept, deny, or work up. Accept means that you're just accepting it. You're adding an assessment in a plan and adding it to your today's assessment. Deny means that you've gone ahead and ruled this out. This isn't an accurate diagnosis, and that does happen. Some folks are more aggressive about coding HCCs or more accurate about coding HCCs than others. And work up means that you want to go ahead and do further investigation, and that's where we go ahead and launch protocols and actually allow you to go ahead and work up that diagnosis to see whether or not the patient actually has it. in addition to what we're doing for the HCC, we actually have now created a high-risk medications alert and automatically present non-high-risk substitute medications. And we did this because even though you might be very, very good at trying to stay on formulary within your physician's office, the patient could be going to other providers who aren't staying on formulary or other hospitals that are prescribing things that aren't on formulary, et cetera. And the patient could suddenly end up on a medication that's a high-risk medication that you don't want them to be on. Instead of just having those things in the medication module, we actually import them and present them again at point of care and actually flag them and say if this patient is on high-risk medications and list out specifically which ones they're on, suggest alternative medications. From that, you can go ahead and highlight that high-risk medication and substitute it out for a non-high-risk medication and stop the old medication in the medication module and prescribe the new medication and send it off. The final piece is we have a case management template, and this allows you to go ahead and work patients with a specific condition. You can either go ahead and send patients to this case management template just by use of a referral to case management, or you can go ahead and tap into that business rules engine that I talked about before, where let's say you want to take and get a list of all of your patients with an A1C over 9 that haven't been seen in the last, let's say, 6 months, and get a list of those patients and then actually work them. So that's something that can greatly help your both your HCCs up by getting those patients in for a visit, as well as keeping your 5-star rating up. And that's actually the last slide. So I wanted to go ahead and open this up for any questions and answers that you guys have. Any questions?
Hang on, sorry everyone, I'm just trying to unmute. Give me one moment. Okay, we've got everyone unmuted if anybody has any questions.
Hello, yes, can you hear me?
Oh, we can hear you.
Oh, hello?
Yeah, we can hear you.
Oh, hi, great. I had typed it into the Q&A box, the question rather, and it's basically this whole recertification of HCC codes, and just to preface a little bit more, we're NextGen users. This whole recertification of HCC codes, what can you speak a little bit more to that, like as to who has to do it, why is it being done, how do we know it, you know, what codes need to be recertified? I mean, like, in order for us to, I guess, attest to these HCC codes in one way or the other, like, they have to be certified from what I'm understanding, and if you could speak a little bit more about that, that'd be great.
Sure. So recertification is just a fancy way of saying that you went ahead and built for the code and have the appropriate documentation to back it up. Every HCC needs to be recertified every single year, and it has to be done within a face-to-face encounter. So on the physician level, what that means is that you need to have a progress note with that diagnosis in it and with an appropriate assessment and plan. And it can be very simple. It can be, you know, continuing to monitor the patient's diabetes, you know, something very straightforward. But it does need to be documented in your note. What's nice about NextGen is, you know, with the new 8 series diagnosis grid, it's very easy to see the assessment and the assessment code and the corresponding assessment details and plan that you put together. What really happens, though, is you go ahead and bill that off to the insurance company to a claim, through either an H37 or a paper claim, and they go ahead and collect all those diagnoses. And then throughout the year, they're actually sending them off to Medicare through a RAPS file, and that RAPS file is what gets them technically recertified. But you as the provider just need to make sure that every single condition that's an HCC has an assessment and plan documented and gets filled out once a year.
Okay, well that was a great answer. I understand it much better now. The issue I think that we would encounter if we were depending on the NextGen template that, as you said, was out of the box. Just basically, we're transitioning from 5.7 to 5.8 right now, and as far as using 5.7 and just I guess utilizing this template that I'm sure exists in 5.7, we don't know if it's possible, like whether or not it's even available, or like just certain things surrounding this the usage of our system right now. And if we wanted to do this whole recertification through, on a paper level, like it would just be a matter of I guess having those claims for every encounter with the patient be reflecting of these HCC codes. That would be good enough, right?
Correct. Yeah. And what I didn't mention is the templates that we were talking about are all on 8.3. So if you're on 5.7, you're not on 8.3 yet. There is an earlier version that's compatible with 8.0, and that would be available to you on 5.7. Which KVM are you running?
Not the 8.3. That the former one, the one prior to that. I believe. Is it
8.0 or 8.1?
Yeah, 8.1. Yeah,
okay.
8.1. Yeah.
There is an earlier version of the Medicare Advantage templates that we have that we could also give you for 8.0 or 8.1, or you could just incorporate it as part of your 8.3 upgrade process.
Wonderful. Sir, I really appreciate that. That whole recertification is a great term to know, and I appreciate your explanation. This was a great presentation, very, very comprehensive, and I appreciate it.
Oh, thanks. Any other questions? Okay, great. Well, as always, if you have specific questions or scenarios that you'd like to discuss, feel free to send us an email at info@corkhealthcare.com, and we'll go ahead and get back to you. We'll also be posting these slides on SlideShare within a couple days, and a recorded version of this presentation to YouTube so you can watch it again. Thanks so much, everybody.
Thank you.